We move now to the second part of this seminar, this webinar, and then I will be now talking. Let me just share the screen with you. And there we go. So continuing our discussion, I'll be talking now a little bit about the burden of disease and the best practices regarding diagnosis of symptoms. And I'll be focusing again on some of the areas that really can make a difference in terms of patient management of patients with angina, patients with chronic coronary syndromes. What sort of strategies can help us to do better diagnosis, better identification, and better treatment of these patients. These are just my general disclosures. This is my hospital here in Lisbon, where I am right now. We usually have quite a lot of fun having colleagues coming from other parts of the world. Hopefully now, with the pandemic getting a little bit more under control, we may be more open to travel and to exchange our presence in different parts of the world. Well, just setting the stage for what we are talking about here, we know that the prevalence of angina can be around 4 to 5% in developed countries. There are some differences among different areas. It may be affected also the prevalence by age, by gender, by ethnicity, geographic region. But what matters is that it's still a very relevant clinical problem that we face on our everyday clinics. And despite the therapies that we have available, about 1/3 of chronic stable angina outpatients are still symptomatic. And despite pharmacological treatment, revascularization, in many cases, patients may even have weekly symptoms or even in some cases, daily symptoms. And this is really a problem that still represents significant burden of disease. And if we look at the patients post-myocardial infarction, about 1/4 of these patients, they can experience anginas soon after discharge. And here you can see nicely that if you see the percentage of patients that may develop either daily, weekly, or monthly angina, this can be 1 out of 4 soon after the acute myocardial infarction. So these were patients who were treated, many of them, of course, now with primary angioplasty, that they've been treated with primary PCI, and still a significant number of these patients, despite this treatment, despite revascularization and pharmacological treatment, they still have angina after the procedure. And about half of the patients continue to experience some sort of angina in the first 4 months after discharge of acute coronary syndrome. This is an analysis from the Merlin TIMI-36 trial, over 5,400 patients. These are stable outpatients who had an acute coronary syndrome. And you can see in this specific case of this data, about half of the patients, they reported some sort of angina, either monthly, about 30%, weekly, and about 16%, and 5% had daily angina. So it's really an important burden in the patients, sometimes not well perceived. And with all the rush that we have every day, sometimes we don't realize. And it's when we look at the data from some of the studies, such as the ones that I'm showing, that we see how much it really represents in terms of our daily practice. And the problem of angina is not only about patient outcome, but also about quality of life and about physical activity. We have here data showing that the patients who have angina, regarding the more frequent the angina, the more impact it has on quality of life in green or physical limitation in orange. So patients who develop either monthly, weekly, or daily angina, they will have an impaired quality of life, and they will do exercise less, they will have more physical limitation, which of course has an impact in terms of quality of life for these patients. We also know that there are common profiles of patients with angina. This is data from the Clarify study, which involved several thousands of patients. And some of these profiles, the most common are being patients with previous history of myocardial infarction, some patients post-revascularization, either PCI or CABG, diabetic patients. So there is sort of a profile of patients who may more likely develop angina, particularly after acute coronary syndrome. Another important element is that angina may be unrecognized by healthcare professionals, and in this case, it can go up to 50% of the time in real life. This is data that's showing that about half of the patients, they were unrecognized by the healthcare professionals, and this certainly has, even in patients with monthly angina, and in about 26% in patients with daily or weekly angina. So it's also a problem that there is some under recognition of the symptoms of angina in our patients. And why is this important? Well, we know that the presence of arthrothrombosis has also an impact in terms of life expectancy. It reduces around 8 to 12 years in patients over 60 years old, particularly patients who have an history of acute myocardial infarction. So it's important to identify these patients. Also, when we look at the outcome of these patients, sometimes there is a feeling that patients with chronic angina or chronic or stable or chronic coronary syndromes, they have a benign condition. Well, if you look at data from the REACH registry, which involved close to 40,000 patients with known coronary disease, at 1 year follow-up, 15 of these patients at 1 year, they had a major event, or they had been hospitalized within that year. So about 15% of the patients, so 3 out of 20 patients, they had a major event or they were hospitalized during that year after they've been recognized with coronary disease. The angina burden also has, on top of a personal impact, also an economical impact. There's a 3-fold higher risk of disability, 1.5-fold higher risk of job loss, and 4-fold higher risk of depression. So it's a full set of potential impact on patients' lives and also on the economical aspects of the society. Let's focus now on the pathophysiology of angina. Well, chest pain, as we all know, can be due to different causes. It can be non-cardiac, it can be cardiac but non-ischemic, or it can be cardiac ischemic. And here we may have different pathophysiologies underlying, and many times coinciding in the same patient, from inflammation to endothelial dysfunction to coronary spasm, metabolic mismatch, smooth muscle dysfunction, and many others that may contribute to the development of chest pain. We also know that ischemic heart disease is a single clinical entity, but may have multiple etiologies. And that's why it requires a comprehensive approach. It may have some aspects related with the coronary vessels, as we've just seen, flow-limiting stenosis, of course, which is the one that sometimes we focus more, but it goes beyond that. Endothelial dysfunction, vasospasm, muscle bridges, inflammation. And then many patients may have small coronary disease, small coronary vessels abnormalities, particularly patients with diabetes or with some endothelial dysfunction and hypertension. There may be some sort of microvascular dysfunction, endothelial dysfunction, spasm, inflammation, microemboli. And then we may have also abnormalities at the level of the myocardial cells. And when there is development of ischemic heart disease, there's going to be an impaired energy metabolism with defective cellular oxygen transport, mitochondrial dysfunction, inflammation, fibrosis, production of radicals of oxygen, which can induce cellular damage, and promotion of programmed cell death. So there is a whole comprehensive aspects and multiple etiologies, many of them that may coexist in the same individual. And that's why we like to look at ischemia as a multifactorial disease condition, where you may have different elements that may be responsible for the development of ischemia, as we've just seen. And this may translate into stable angina, but you may have all these different elements that in many patients, they may coexist. What we also know, and this is data that was published a few years ago, in about 2,500 patients that were new patients with angina, there was a substantial number of these patients, all of them, they underwent coronary angiography, and many of these patients, they had no evidence of epicardial coronary disease. So patients with symptoms of angina, and many of these, they don't have obstructive coronary disease. So they have some of the other pathophysiological elements that can explain why the patient develops angina and ischemia, although he may not have significant obstructive coronary disease. And this is an important concept because for many years we thought that the coronary disease and ischemia was mainly due to the occlusion of the epicardial vessels. Of course, that's the reason for some patients, but we know today that in many patients, and even in those patients who have obstructive coronary disease, when relieved the obstruction, as we have seen at the beginning of my presentation, many of them still have angina because they have other etiologies, other pathophysiology substrates that may explain the presence of ischemia. Also, these new patients with angina, they already have, many of them, some comorbidities. In this study, you can see that many of them had a hypertension, dyslipidemia, diabetes, COPD, some with renal dysfunction, with peripheral artery disease, many of them with some history of previous myocardial infarction or stroke, many smokers. So many of these patients with angina, they already have some comorbidities that may actually explain also some of the changes that we observe in this patient population. And many of them, they already have under some treatment. They are not totally treatment naive. You can see that about half of them, they were already on platelet inhibitors for some reason, on beta blockers, ACE inhibitors, AT1 receptor blockers, and even calcium antagonists. So this set of patients, although they may not have obstructive disease, but they already have some sort of abnormalities that may explain why they develop angina. Now, just to reinforce here the concept that angina reduces the quality of life and reduces at any severity of coronary stenosis, precisely because the presence of angina and ischemia, it may occur regardless of the presence of coronary stenosis. And you can see here that regardless of either the patient having normal coronary arteries, epicardial arteries, diffuse non-obstructive disease or obstructive disease, the patients who had a more severe presence of angina, meaning more frequent episodes, this was actually the limiting factor. These were the patients who had more reduced quality of life. So it's angina that impacts on the quality of life and not necessarily the severity of the coronary stenosis. And again, this is relatively a new way to look at this condition. Also, the presence of angina, regardless of the coronary anatomy, results in worse outcome. You can see here that the patients who were asymptomatic, they had better prognosis than the patients who were symptomatic, regardless of the severity of coronary disease, either no obstructive disease or 1, 2, or 3 vessel disease. So again, angina itself is related with the patient outcome, regardless of the severity of coronary anatomy. Now, why is it important to recognize the presence of angina? As I mentioned before, in many cases, we have now data showing that there may be an under-recognition of the presence of angina. And if that happens, if there is an under-recognition of angina, this delays treatment escalation. And this is a problem because if there is a delay in treatment escalation, of course, we are not managing properly these patients. And you can see here that under-recognized patients, they have a much more delayed treatment escalation, and actually less percentage of these patients will be on the full treatment that they should be in according with the recommendations and with the drugs that we have currently that can help us to manage patients with angina and patients with ischemic heart disease. So it's about 1/4. And again, about 44% of these patients are on suboptimal anti-anginal therapy. So if you look at the intensity of the anti-anginal pharmacological management for patients who have frequent angina, and that means daily or weekly angina, you can see that about half of these patients, they are either on no treatment or only one drug. When we know today that it's the combination of these different drugs that can actually help us to manage these patients. So very important to recognize the presence of angina so we can start appropriate treatment in these patients. And that's what's also covered in the ESC guidelines. Let me just give you a little bit of a flavor of the last, they were published 3 years ago, 2019, the guidelines on the diagnosis and management of chronic coronary syndromes. First of all, one important concept, the acknowledgement of the multifactorial origin of ischemic heart disease, as we've just seen. So it's now a syndrome, it's a chronic coronary syndrome. Also, it was recognized that there is twice lower pre-test probability of obstructive coronary disease, confirming that the genesis of angina goes beyond coronary stenosis. And again, this is based on revised data, precisely showing the importance of angina itself beyond obstructive coronary disease. Then, very importantly, only about 15% of the patients present, 10 to 15% present with typical angina. So the majority of patients with suspected of having coronary disease, they present either with atypical or even with non-anginal chest pain. And this fosters the need of active monitoring for angina or equivalent symptoms. And now it's included in the guidelines, not only chest pain, but also dyspnea, which can be an equivalent of angina of ischemic heart disease. And this is where we can see here the natural history of chronic coronary syndromes, and showing that it's a dynamic process. It may go from an asymptomatic status to the need of revascularization to the presence of symptoms again. And there is a clear temporal cutoff here. So patients who have an established diagnosis less than 12 months, so in less than 1 year, these patients are now considered as recently diagnosed. And this will have an impact because in these patients, they should be seen now, according with the guidelines, at least 4 times within the first year. And then the goal here is, on one hand, for treatment assessment and do all the up titrations, all the combinations needed to treat these patients, but also on risk evaluation. So the aims of the pharmacological management of chronic coronary syndromes are to reduce angina symptoms and exercise-induced ischemia and prevent cardiovascular events. There is an acknowledgement also of the lack of evidence regarding the superiority of all the different anti-anginal therapies and the need for a patient-tailored approach. And here we have different quotes from different publications. It's a reality that the evidence regarding superiority of one against the other is not so strong, and many of them is based in old studies in different conditions. So the initial drug therapy usually consists of 1 or 2 anti-anginal drugs, plus drugs for secondary prevention of coronary disease. But what is important here is that there should be a patient-tailored approach according with what is our perception of the mechanisms, the pathophysiology that underlines the presence of ischemia in our patient population. This is some of the novelties of the guidelines. For instance, the use of imaging or the use of some drugs that have been upgraded. For instance, the use of some metabolic agents such as trimetazidine or the use of ivabradine, the icorilenol for second-line treatment is now a 2-way recommendation. So that's an upgrade so it should be considered, and that's an upgrade from the previous guidelines. And yet, if you look at data from, for instance, from the Clarify, 51% of angina patients, they remain symptomatic and at high risk for cardiovascular death and MI despite standard treatment. So we have to be better at treating and managing these patients. And we should be focusing on optimal medical therapy. And what is optimal medical therapy for symptom control in patients with chronic coronary syndromes? Well, there is no universal definition of which drug combination is optimal. Anti-ischemic drug therapies, they must be adapted to each patient's characteristics and preferences. And initial drug therapy usually consists of 1 or 2 anti-anginal drugs as necessary, plus drugs for secondary prevention of cardiovascular disease. Of course, this will depend on the expected tolerance that is related to the individual patient's profile and comorbidities, potential drug interactions with co-administered therapies, patient's preferences, of course, after being informed of potential adverse events and effects, and of course, drug availability, which may change a little bit in different parts of the world. So we can define the optimal treatment as a treatment that satisfactorily controls symptoms and prevents cardiac events associated with chronic coronary syndromes with maximal patient adherence, fundamental and minimal adverse events. And that's why when we look at data, for instance, coming from the ischemia trial, where again, it's a clear example that pharmacological approach is still the cornerstone therapy for patients with chronic coronary syndromes. In fact, early invasive strategy did not further reduce death, myocardial infarction, or hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest in chronic stable ischemic patients. We're talking about chronic stable ischemic patients. And again, this shows the relevance of a very robust pharmacological approach to these patients. And that's why we've been promoting this diamond approach. So it's a therapeutic approach according to the clinical features and the presence of comorbidities. And again, it allows us to be flexible on the use of the different drugs that we have available to do anti-anginal treatment. For instance, patients with angina, with heart rate over 70, with symptomatic on beta blocker, we can see that we probably should reduce heart rate. In this case, if the patient is not on diltiazem or verapamil, we can include ivabradine, for instance. So there is a combination, for instance, of beta blockers or non-pyridine calcium channel blockers, or if that's the case, and if the patient is not on one of those, to include the presence of ivabradine to reduce the heart rate. This is just an example. Patients with heart failure, here again, the use of beta blockers and include either long-acting nitrates or beta blocking ivabradine or another of the so-called second-line drugs can be utilized. Just a couple of examples on how, according with the characteristics of the patients, we should use combination of different treatments. And this is very important because what we've learned from randomized clinical trials is that optimal medical therapy remains unacceptably low in many of our patients. And PCI does not necessarily reduce incidence of cardiovascular events in patients with chronic coronary syndromes. So an initial course of optimal medical therapy, at least for 3 to 6 months, in all, but mostly in the symptomatic patients, represents what we can call a clinically appropriate, evidence-based, and cost-effective approach. Also, very importantly, that the team-based and patient-centered approach is highly desirable in our patient population. So I would conclude, first of all, that angina pectoris is a very common symptom of coronary disease and affects around over 110 million people at the global level. In more than half of the angina patients, symptoms can actually seriously restrict everyday activities, quality of life, and in many times they can lead to premature retirement of patients that are still at the working age. Acknowledgement of the multifactorial origin of ischemic heart disease from disease to syndrome. There is a clear temporal cutoff now. So patients with an established diagnosis less than 1 year, they are considered as recently diagnosed, and these patients should be seen at least 4 times within the first year for treatment assessment and risk evaluation. There's an acknowledgement of the lack of evidence regarding the superiority of the anti-anginal therapies and the need for a patient-tailored approach. The affirmation of the need for more than one anti-anginal drug for angina relief and the need for an early response to medical treatment is also clear. Of course, revascularization remains an option, but that should be also done only after failure of optimal medical therapy in patients with chronic coronary syndromes. So with this, I finish my presentation.